Sore, flat nipples, and jaundice in the newborn.
Hi, my name is Alyssa. This is my video for NSPN 7155. I will be using the Situated Clinical Decision Making Framework to help me work through my breastfeeding complication, which is sore, flat nipples with a jaundiced newborn. This framework includes knowledge, cues, judgment, decisions, and evaluation of outcomes. I have enclosed a PowerPoint for you to view. Thank you.
Sore, flat nipples, knowledge, and cues. Some causes of flat nipples are adhesions at the base of the nipple or anomalies due to the short lactiferous ducts holding the nipple in, preventing projection. Some flat nipple observations are you are unable to visually assess, there is little or no nipple protrusion, there is a lack of definition between where the nipple ends and the areola begins. This is often first noticed when breastfeeding difficulties arise. During the pinch test, a gentle squeezing of the areola behind the nipple flattens to the level of the areola. Some causes of sore nipples are candida infection, infant tongue tie, hypersensitive nipples, Raynaud's phenomena, and poor latch. Some sore nipple observations include red, bruised, cracked, scabbed, bleeding nipples. The nipple may be misshapen or distorted after a feed. Jaundice, knowledge, and cues. When an infant is in utero, they are living in a low oxygen environment. In order to get adequate oxygenation to all the body's tissues, the infant makes more red blood cells. A normal byproduct of red blood cell destruction is bilirubin. When in utero, the infant eliminates all excess bilirubin to the mother via the placenta. Upon birth, the environment changes rapidly from a low oxygen environment to a high oxygen environment. This increases the number of red blood cells destroyed as they are no longer needed because of the higher oxygenation of room air. This leaves the baby completely responsible for the elimination of bilirubin. In a normal cascade of bilirubin metabolism, the liver breaks down the bilirubin, which is then excreted as bile into the intestines and eliminated as meconium stools. Any defects along this cascade can result in high bilirubin, which is a yellow pigment that is deposited in the skin, muscles, and mucous membranes. The significance of high bilirubin is that it can have neurological consequences, such as bilirubin encephalopathy, which is acute or a more chronic condition known as kernicterus. Although in extreme levels bilirubin is dangerous to the infant, in lower doses bilirubin is actually an antioxidant, showing protective effects on the infant. There are 3 types of jaundice: physiological, pathological, and breast milk jaundice. Pathological jaundice, or liver disease, appears in the first 24 hours of life. Total serum bilirubin level is higher than 17 milligrams per deciliter in a full-term newborn. Some potential causes are sepsis, rubella, toxoplasmosis, hemolytic diseases such as Rh isoimmunization, ABO blood group incompatibilities, erythrocyte disorders such as G6PD, cephalehematomas and bruising, inborn errors of metabolism, hypothyroidism, polycythemia, intestinal defects or obstructions, and maternal diabetes with a macrosomic baby. Physiological jaundice is normal as the infant adjusts to a higher oxygen environment. It is not seen in the first 24 hours and usually rises during the first 3 to 4 days, peaking on the 5th day and starting to decline thereafter. In preterm infants, this peak may not be seen until the 6th or 7th day and then start to resolve. It can be associated with ineffective breastfeeding, inadequate milk or calorie intake, having a sibling with jaundice, excess weight and water loss after birth, maternal diabetes, infection, and hematoma and bruising. The last type of jaundice is breast milk jaundice. This is seen after the 5th day of life and peaks around the day 12. Serum bilirubin is between 12 and 20 milligrams per deciliter. It can last up to 3 months. One theory to the cause of breast milk jaundice is that certain components of the breast milk may inhibit bilirubin metabolism. Although the factors are unknown, there are several theories. Jaundice cues. The infant will have yellow skin progressing from head to toe. The infant will be sleepy, have poor feedings with a weak suck, and decreased alertness. Some tests we use to check for jaundice are a blood test for bilirubin if the assessment findings support this, a Coombs test to check for any blood incompatibilities, a blood test for thyroid and G6PD, a Kramer's skin color assessment which divides the body into 5 zones which correlate to serum bilirubin levels based on the skin color blanched by the thumb. As well, we could use monitoring input and output, ensuring adequate elimination of meconium stools, as well as monitoring weight loss. Judgment. What are the factors affecting the breastfeeding relationship? The mother has flat, sore nipples, making it hard for the infant to latch properly, therefore damaging the nipples. Due to the pain, the milk letdown may be altered. There may be inadequate stimulation to the breast due to a poor latch and a sleepy baby. The jaundiced baby has a weak suck and is sleepy at the breast, leading to poor milk transfer and decreased colostrum intake, affecting the ability to pass meconium stools and eliminate bilirubin, therefore increasing jaundice. Who should I consult? First, we should consult the doctor for a treatment plan for the jaundice. Then we should talk to the lactation consultant to work on latch and milk transfer. Thirdly, we need to talk to the public health nurse if the baby is at home to monitor jaundice levels and to ensure breastfeeding success. The priority for this breastfeeding dyad is to feed the infant, move the milk, and help the pair learn to breastfeed. For feeding the infant, this includes improving latch and milk transfer, giving the infant express breast milk or donor milk via cup, syringe, or spoon, and if human milk is unavailable, we may need to supplement with formula. We need to move the milk by getting the pair to breastfeed at least 10 to 12 times in a 24-hour period. If the infant is sleepy at the breast or weakly suckling, then the mom needs to pump or manually express her breast after each feed. Lastly, we need to help this pair breastfeed by teaching the mom what a proper latch looks like and feels like, how to monitor wet and dirty diapers appropriate for the child's age, and we need to encourage and support this pair to ensure breastfeeding success. Decisions. Some treatments for jaundice are the 3 E's, which is early and often skin-to-skin contact and feedings, effective feeding including proper latch and milk transfer, and exclusive breastfeeding excluding all artificial teats and pacifier. An injection of RhoGAM or high titer anti-D immunoglobulin G for blood group incompatibilities. The use of phototherapy, which uses light energy to change the structure of bilirubin, making it easier to metabolize and eliminate. This can also be used in a portable way, such as using billy blankets. Support effective breastfeeding, giving express breast milk if necessary. If unable to breastfeed or pump milk, then supplementation with formula may be medically indicated. Exchange transfusion, only in extreme cases, for newborns with hemolytic diseases. We must treat the sore nipples with express breast milk and letting them air dry, using saline soaks for scabs, and using heat before feeds. Also, there are several ways to draw out a flat nipple, such as using a breast pump before feeds, suction devices such as averted nipple enhancers, nipplettes, modified syringes, and supple cups. Most of these use some sort of suction to withdraw the nipple. Another technique to draw out the nipple is to apply cold compress to the nipple and gently pull and roll the nipple, making it easier for the infant to latch. Evaluation. How are we going to evaluate this plan? Is the infant feeding more effectively? Is the jaundice subsiding? Are the mother's nipples less sore? Are they healing? Is this infant gaining weight and having adequate urine and stool elimination? How is this mother feeling about breastfeeding? If these answers have improved with your plan, then your plan is working.
In conclusion, when a mother has sore, flat nipples, this can make getting a proper latch difficult. This is even more challenging when you have an infant with a weak suck and falling asleep at the breast, such as a jaundiced newborn. As long as we implement the 3 priorities or rules, we can improve breastfeeding. These rules are: feed the infant, move the milk, and help the dyad learn to breastfeed. We hope to see improvement with latch and effective breastfeeding, as well as an increase in milk intake. we should start to see the infant's jaundice start to resolve and the mother feeling more confident with breastfeeding. Thank you.